Hello everyone, this is Dr. Vasquez, and today I'm going to talk about assessment of renal function. The reason that we're going to talk about this is because last week we talked about hypertension and diabetes. These are the two most common diagnoses in the practice of general medicine or family practice. And also you'll see number 10 here is urinary tract disorders. Often this includes urinary tract infections. It can include a lot of other things too. But within this context, let's focus on urinary tract infections, which often start simply as bladder infections but can ascend to become a kidney infection, and that can cause kidney damage. So let's talk about how to assess kidney function. As most of you know by now, my clinical practice focuses on the treatment of chronic inflammatory and autoimmune diseases, and so I often have to check their kidney function as well. So as I've said before, a lot of times when we're treating patients in clinical practice, we're not simply treating whatever their so-called primary complaint or their chief complaint is. Patients come in to me with a complaint of fibromyalgia or rheumatoid arthritis or lupus or psoriasis, but a lot of those patients have hypertension, diabetes, hypothyroidism, and a lot of times they'll have impaired renal function as well due to the diabetes or the hypertension or the drugs that they're on or the disease itself. So very often we have to assess and monitor their kidney function as we're going through their treatment protocol. So as I say here, we must check renal function in patients with inflammatory diseases for the following reasons. Number one, many inflammatory and autoimmune diseases actually cause renal damage. This is very true for patients with lupus who often develop a subsyndrome, we might call it, called lupus nephritis. Systemic sclerosis, one of the major causes of death in those patients is hypertension, including pulmonary hypertension, and often renal failure as well. Wegener's granulomatosis and all of the other vasculitic immune complex mediated diseases often have renal impairment as part of the clinical picture there too. So again, when we're managing these more complex metabolic and inflammatory diseases, we often have to take into consideration what's going on with the kidneys. Many autoimmune disorders and all of the vasculitic diseases have circulating immune complexes as part of the disorder. These immune complexes are predisposed to deposit in the skin. That causes nonspecific dermatitis, joints, which of course causes arthritis, and the kidneys to cause nephritis. Also, many anti-inflammatory, immunosuppressive, and analgesic drugs can actually cause kidney damage. So, classic example of that are the non-steroidal anti-inflammatory drugs, which when taken for long periods of time, as they are often used clinically, do cause kidney damage. Coexistence, as I mentioned before, of metabolic syndrome, diabetes mellitus, hypertension is very common among these patients. Obesity, for example, is one of the common themes. Obesity and insulin resistance are two of the common themes, of course, between metabolic syndrome, diabetes, hypertension, and obesity, and all of those increase the risk for these chronic inflammatory disorders. So, for example, patients who are obese are at higher risk for having severe asthma. Patients who are obese are at higher risk of having really severe autoimmune inflammatory disorders such as psoriasis. Implementing health-promoting dietary change in patients with renal insufficiency may precipitate hyperkalemia, and that's one of the major points that I'd like to emphasize in this brief presentation. A lot of times we use the dietary protocol that we've already reviewed, which is my 5-part protocol, the first part of which, of course, is what we call generally a paleo-Mediterranean diet, which is very rich in fruits, vegetables, nuts, seeds, berries, and lean sources of protein. Well, along with those fruits, vegetables, nuts, seeds, and berries, of course, we get a lot of great phytonutrients, but we also get a big dose of potassium. Now, the kidneys can handle, healthy kidneys can handle any daily intake level of potassium. The current recommended intake from the Institute of Medicine Food Nutrition Board is 4.7 grams per day for adults. Only about 10% of adults eat enough fruits and vegetables to actually get there, which is another way of saying that 90% of patients actually need more potassium. We would, of course, love for them to get that in fruits, vegetables, nuts, seeds, and berries, or fruit juices, or the least whole foods option would be just a potassium citrate supplement, which is also now commercially available. But we need for our patients to have sufficient potassium intake to regulate blood sugar, mood, nervous system function, as well as insulin resistance and glucose control. So we can do the right thing, which is put patients on a diet that's high in fruits, vegetables, nuts, seeds, and berries, but if we do the right thing in the wrong patient, namely a patient who already has kidney disease, we could end up causing a problem, because if the kidneys aren't functioning properly, they won't be able to excrete potassium. And if they can't excrete potassium, patients can end up with a condition called hyperkalemia, which can be life-threatening. Let's look at a case. This was a case in my family medicine practice in 2010. This is a 69-year-old African-American woman who presented just for a routine checkup. She had some health problems, and as I recall, at the very least, she was obese. If you look at her blood sugar, it's 98. That's considered quote-unquote normal, but it's certainly not optimal, and we've reviewed that previously last week in our discussion on hypertension and diabetes. But let's focus in on her eGFR, which stands for Estimated Glomerular Filtration Rate. You can see that her number comes back at 54. That is not sufficient. Anything below 60 is considered chronic kidney disease stage 3. So right off the bat, we're alerted to the fact that this patient has impaired renal function. But the big red flag on this result is the potassium level. Her potassium came back at 8.5. She's completely asymptomatic, which means she wasn't coming in with any specific problem per se. But when we look at serum potassium, obviously we're looking at the numbers, and you can see the top of the range here is 5.3. Anything above 6 is what we would consider to be a panic value. Because when patients have elevated potassium in their blood, that can cause cardiac arrhythmia or ultimately can cause cardiac arrest. So if 6 is a panic value, how do you think we felt when we saw her level come back at 8.5? Now, sometimes potassium can be elevated in a blood sample because the blood sample may have not been stored or shipped or processed properly. But as you can see from the lab, they rechecked and verified these results, and there was no visible hemolysis. If the red blood cells explode, or lyse, as we say, they release potassium, and that can cause what we consider to be a false elevation of the potassium in the blood sample. But in this case, the lab confirmed that the result was accurate, and they specifically said no visible hemolysis. So we have to believe that this is a reliable result, and we have to act on it. And again, we're looking at potassium of 8.5. 6 is a panic value, so 8.5 is outrageous. So we had this patient transported to the hospital immediately. We'll look at a few other abnormalities that were noted here too. Her hemoglobin A1C is 7, so she is diabetic. And you can see her TSH toward the bottom of the page is 10.6. So we've got 3 very obvious abnormalities here. And we'll point out a few others. Hopefully maybe if you take a quick look at these labs before I progress, you'll be able to point out the other 4 abnormalities here as well. So how do we check kidney function clinically? Well, classically what we've done, and this is what we learned in medical school, we use an equation called the Cockcroft-Gault equation. So you can see the mathematics as I've diagrammed them here. We take the number 140, we subtract the patient's age in years, we multiply that by the weight of the patient in kilograms, and then we factor in gender by multiplying 0.85 if the patient's female. And we divide that by the number that we reach by taking 72 and multiplying that by the patient's serum creatinine. That's called the Cockcroft-Gault equation. The nice thing about the Cockcroft-Gault equation is that it can be done, as we say, at the bedside. So all you need is a pencil and a piece of paper. If you have the formula memorized like we had to do in medical school, then you just take the lab results and perform the equation. A lot of labs these days will actually give you the eGFR on the paper, so you don't have to actually do it yourself. And that's fine, but in a lot of times, especially in hospital and public health settings, the labs weren't quite so generous and they wouldn't give us the number. We had to do it ourselves. And so we use this relatively simple equation, again known as the Cockcroft-Gault equation, to calculate the patient's estimated GFR. These days, there's a more recently developed and validated equation called the MDRD equation, which isn't something necessarily that you would do in your head, but you can certainly do it online, and you can also get an app for your smartphone and just plug in the numbers, and it gives you the GFR value that you need for your patient. MDRD stands for Modification of Diet in Renal Disease. It's considered to be more accurate than the Cockcroft-Gault equation, but again, nice thing about Cockcroft-Gault, all you need is a pen and a piece of paper and you can figure it out. MDRD, you have to go online or you have to use a special calculator. Another way that we can look at kidney function is simply by looking at the serum creatinine. When we get a chemistry or metabolic result back, it will of course report the serum creatinine. And anytime we see that number above 1.4 in a woman or 1.5 in a man, there's a problem. Now, really, clinically, 1.4 and 1.5, those are actually pretty high values. But it is at those levels that we need to start modifying patients' diet and taking them off certain drugs. One of the drugs we talked about last week in this course is metformin. It's one of the so-called go-to or first-line drugs for insulin resistance, type 2 diabetes, metabolic syndrome. And those patients cannot tolerate that drug if their kidney function is declining. So what we were taught in medical school is anytime we had a patient, if a woman had a serum creatinine of 1.4 or a man 1.5, we would have to take them off of metformin. Otherwise, they're at risk for developing a syndrome, which can be fatal, called metabolic acidosis. So here are my summaries of clinical pearls for managing the patient with declining renal function. When the GFR is below 60, we call this CKD, or chronic kidney disease stage 3. We have to modify doses or withdraw certain drugs. The goal here, of course, would be to treat the causative problem and or begin specialist co-management. So at this point, if you're kind of a consulting nutritionist, or if you're just a general practitioner and you don't want to take on the risk and potential liability of a case like this, then you could certainly start to manage this patient in conjunction with another professional, such as a really well-trained family medicine doctor or an internal medicine doctor. It'd probably be a little premature to refer a patient like this to a nephrologist, but you certainly could, depending on the clinical situation. But it would be reasonable to start co-managing a patient like this, because at some point, typically what happens with chronic kidney disease is that it's progressive. And in the medical world, they consider it to be irreversible. Now, of course, in the nutrition world, we have some options for treating these patients, because we can treat them effectively and we can reverse chronic kidney disease. And that's the nice thing about using safe and effective nutritional interventions, is we can do things a lot of times that the medical specialist can't do. So at this point, I think it's reasonable also for us to start keeping an eye out for hyperkalemia with increased fruit and vegetable consumption. When the GFR gets to 30 or below, we call that chronic kidney disease, CKD, stage 4. Patient definitely needs to be in contact with a nephrologist at that point. And by the time they get to GFR of 15, we call that chronic kidney disease, stage 5. Patient needs a transplant or dialysis. So if you have these numbers in mind, you can keep these numbers and your patient's results in perspective and therefore understand how to manage them. So typically what I've done, for example, when I teach pharmacology, is I would present labs on a given patient, and I would have the students, they would have to have memorized the Cockcroft-Gault equation, often very much to their resistance, and then apply that equation and then determine what the proper management is, because that's what we have to do clinically. We simply get the results back from the lab. We sometimes have to do the math ourselves, which is not a big deal, or we use the MDRD equation through a calculator or a website. And then once we get that estimated GFR, we have to take action on it. And if it's above 60, we're okay. If it's below 60, we're in trouble. So it's important to remember that real, true chronic kidney disease starts at a GFR of 60 or below, and at that point, we have to start modifying drugs and diet. By the time they get to GFR of 30 or 15, they very much need to have already been in the pipeline to see a specialist, because, for example, for patients who are of low financial and insurance resources, it can take months, sometimes years, to find a transplant donor for them, or to get them in the pipeline to receive dialysis and other home treatments and things like that too. So it does take some planning ahead by the clinician to make sure our patients are properly managed when their kidney function is starting to decline. Another test that's recently become available is called cystatin C. Cystatin C is a protein made by all nucleated cells in the body, and this protein is filtered by the glomerulus. So unlike serum creatinine, the concentration is not affected by diet, muscle mass, or acute inflammation. And I've given you some reference ranges there, depending on the laboratory methods that are used. So basically, when we think of cystatin C, we think of it as being elevated in renal disorders. We think of it as a good predictor for the severity of ATN, which is acute tubular necrosis. Cystatin C increases more rapidly than creatinine in the early stages of renal impairment. Cystatin C concentration, just like creatinine, but more sensitively than creatinine, and similarly with C-reactive protein, is an independent risk factor for heart failure, mortality, cardiovascular disease, and non-cardiovascular disease outcomes in older adults. and it appears to provide a better measure of risk assessment than serum creatinine concentration. It will probably become the test of choice for assessing and monitoring kidney function in the future. Last time I checked, the retail cost was about $80, but of course that will get lower as more doctors use the test. So here's a patient that I reported in one of my more recent books called Foundational Assessments and Wellness Promotion in Integrative Chiropractic and Functional Medicine. This is a 40-year-old male presenting for follow-up on abnormal renal function, and in this case I had to use a cystatin C to kind of make sure this patient was okay. You can see his serum creatinine is getting a little suspiciously high here. It's at 1.41. Again, 1.4 in a woman or 1.5 in a man is considered a problem. So I was a bit perplexed why this young, athletic, otherwise very healthy young man was starting to have problems with his serum creatinine level. So, and this was a consistent finding that we saw in about 2 or 3 consecutive results. So, we needed to take some action on this and not just assume it was a laboratory error, because I don't think it was a laboratory error. According to the lab, his EGFR, he's non-African American, is 62. That's getting a little bit low for someone who's, 40 years old. So that didn't seem normal to me. So in this case, I used cystatin C, and the result came back completely normal. So then I didn't have to concern myself with this patient's apparent, quote-unquote, apparent decline in renal function. So again, we always start with the basics, BUN, creatinine. If creatinine looks suspicious and we repeat that and it's again suspicious, then I think it's appropriate to go to cystatin C, of course, along with coordinating our evaluation with the patient's physical exam and assessment and diagnosis. So here are our assessments. We talked about serum creatinine. Again, 1.4 in a woman, 1.5 in a man. I showed you the Cockcroft-Gault equation. If you were in my pharmacology class, you'd have to memorize that and know how to apply it. We also have the MD-RD equation. That's modification of diet in renal disease. We have cystatin C. On a random urine sample, we can also perform what's called an albumin to creatinine ratio. So in this case, rather than doing a routine urinalysis, we would also send the urine to the lab, and we would have them check this albumin to creatinine ratio. That is an early and very sensitive marker for kidney disease. So let's go back and look at this result that I had introduced you to just a few moments ago. So I'll pause for just a moment. I'd like for you to look at the results and see what you come up with in terms of your assessment and management for this patient. So let's start at the top and work our way down. Glucose is 98. Now, from a medical standpoint, that's normal. But from an optimal health and functional medicine perspective, that is certainly not optimal. So as I mentioned to you last week in our conversation about hypertension and diabetes and metabolic syndrome, we want to see that fasting glucose below 85, because if it's higher than 85 on a fasting sample, that correlates with increased risk for cardiovascular disease, and I think it's a surrogate marker for insulin resistance. So yes, it's normal, but it's certainly not optimal. Let's see what else we find. BUN looks okay. Creatinine's a little high, though. Remember, 1.4 in a woman is suspicious, and she's at 1.2, so I would flag that in my own mind. If you look at her creatinine in conjunction with her other anthropomorphic parameters, we get a GFR below 60. I'm not happy with that. Her GFR for an African American is at 54. So she's in trouble. So we call this chronic kidney disease stage 3. At this point, our obligation is to modify drugs and diet. The reason that we modify diet is to make sure that this patient doesn't develop hyperkalemia. And in this case, she already has hyperkalemia. So this proves the point. This is not a patient who is vegetarian and juicing 5 pounds of carrots every day. This is a patient on a normal diet. I don't right now recall what her drugs were, but she certainly had no major risk factor for hyperkalemia. But again, she's almost dead with hyperkalemia according to this result. So potassium of 8.5 is considered emergency. Look at our triglycerides. We talked about these last week. I like to see triglycerides below 100. Anytime we see triglycerides above 100, I believe that that's a marker for insulin resistance. We also see that high in some people who have a so-called genetic disorder. Even though I think that term gets overused. Also, we see high triglycerides in patients who consume a lot of alcohol. So when you see high triglycerides, I want you to think insulin resistance, alcohol, or some type of genotropic disorder, but also excess carbohydrate consumption. In the medical world, they'll take a patient who has elevated cholesterol and triglycerides and they put them on drugs forever. In our case, and from a functional medicine and nutrition standpoint, we can treat those patients with diet for about a month and normalize things. Look at her LDL is a little bit high too. Now, it's high because this patient's diabetic, and we found out that she's diabetic by looking at her hemoglobin A1C level. So notice that her glucose is normal. So if we had just used a fasting glucose as our test to see whether or not she's diabetic, we would have missed it. But her hemoglobin A1C is what's telling us the truth. Hemoglobin A1C above 6.5% is diagnostic now for diabetes. And so she's definitely diabetic. In our diabetic patients, as I reviewed with you last week, we want to see that their LDL, all of their lipid parameters need to be optimized because they're already at high risk for cardiovascular disease. So in her case, we need to see that LDL below 100, and it's at 115. Also, you'll notice at the bottom, her TSH is very high. I like to see TSH below 2. If it's above 3, I consider that to be highly suspicious. And this patient's at 10, so she has primary hypothyroidism. If there are no contraindications, like in her case, there could be some cardiac arrhythmia or something like that might make us slow down a little bit. But otherwise, we need to go ahead and give her some thyroid hormone. Most medical doctors will use T4, even though that's the inactive hormone. That's just the routine in the practice of medicine, but as we've said before, routine doesn't mean optimal. A lot of these patients do better if they're on a combination of T4 and T3, or what I use most often clinically is T3 by itself. It has a half-life of a day, so people only need to take it once a day. Sometimes we split the dose into 2 doses per day, but I find that T3 works quite well, especially for patients who have what we've discussed in this course previously, peripheral hypothyroidism or functional or metabolic hypothyroidism. In this case, though, patient clearly has primary hypothyroidism. So do we want to use T4, T3, or a combination of T4 and T3? In her case, I'd probably go with a combination of T4 and T3. So thank you for your attention. This was an introduction to our topic of the week, which is genitourinary disorders. And so I wanted to give you a quick overview of how to assess renal function within a clinical context. Thank you very much, and I will see you all on the